to you joining us today. This is the second track of the WHO Religions for Peace Global Conference. And the theme of this track is collaboration in health emergencies, WHO, faith partners, and national governments. It's really a pleasure to welcome you here today. If you haven't already met me, I am Sarah Hess and I work in the Health Emergencies Program at WHO in Geneva. For the first part of this webinar, we will be talking a little bit about our recent global strategy that is being published today. So we're very excited about this. This is the WHO strategy for engaging religious leaders, faith-based organizations, and faith communities in health emergencies. I want to just acknowledge from the outset our community of practice that we have been working with for the better part of a year actually to co-develop this strategy. It really has been a wonderful collaborative effort and I really want to acknowledge them in this process. I'm going to hand over first of all to my director, Dr. Sylvie Briand, who it's under Sylvie's leadership that this work takes place. And so I'd really like to welcome Sylvie, and Sylvie's going to give some opening remarks, and then we will talk a little bit more in depth about this strategy. And then we will go into the larger portion of this webinar, which is looking at a very exciting and a case study of collaboration coming from Kenya. So Sylvie, over to you.
Many thanks, Sarah, and good morning, good afternoon, good evening, everyone. It's a real honor for me to welcome you today for the second track of this conference, hosted jointly by WHO and Religions for Peace on strengthening national responses to health emergencies, WHO, religious leaders, faith-based organizations, faith communities, and national governments. This track will showcase different models of collaboration between ministries of health, WHO offices, and faith-based organizations in response to COVID-19 in 3 countries from Kenya, Zimbabwe, and the Philippines. These case studies illustrate key elements of the recently finalized World Health Organization strategy for engaging religious leaders, faith-based organizations, and faith community in health emergencies, which I'm delighted to launch today. This is an important step forward for WHO, as this strategy was co-developed with faith-based organizations from our joint communities of practice. And this is a really important step forward for WHO because it's a new way of working. And this way of working has yielded already very significant results. And we are very happy to continue on this track with you all. It also demonstrates our shared commitment to work together in the long term. The document will eventually sit within a broader strategy for engaging civil society under the WHO framework of engagement with non-state actors, and thus have a permanent role. I supported the development of this strategy because WHO recognizes the important role played by faith communities in society, in health emergency, and in the ongoing provision of health, education, spiritual, mental, and social health care in many countries in the world, which form critical elements of the national pandemic preparedness. The planning and organization of these country case studies has been led by our colleagues in the respective country office. So thank you to all, and to our colleagues in particular who have worked so hard to put this unique webinar together, which demonstrates how this strategy works in practice. I wish you a very fruitful conference and very fruitful exchanges. I'm looking forward to the results of this collaboration. Thank you very much.
Wonderful. Thank you so much, Sylvie, for your comments and for joining us here today. We normally would have our co-host here Dr. Curia from Religions for Peace, who would give opening comments too, but I believe he's having some difficulty joining. And so hopefully at a later point, we will be able to hear from Dr. Curia. But right now, I'd really like to hand over to Sally, Sally Smith, and I'm sure many of you know Sally. She has been a wonderful support to us during the pandemic, supporting the work that we've been doing with the faith communities and the faith engagement. And Sally is going to talk us through some of the elements of this global strategy. So Sally, over to you, and I will share my screen.
Good morning, everyone. And thank you very much to Sylvie and to Sarah for your introductions. And it's just a wonderful opportunity to be able to work together with this team. And too, I'm very excited about this global strategy that's been developed. It really does set a framework for the engagement of faith actors with WHO in a range of different areas. And it's been a really exciting process over this year to develop it together with colleagues from the community of practice, from faith-based organisations. So I think the first thing to say is that this is very much a joint and a shared piece that we've developed together. And I'm also very excited to see colleagues from Kenya here, who are one of the countries who've really modelled this at a country level, not only in the COVID response, but building also on their many years of engagement with faith communities in other issues, such as the HIV response, for example. So you can see there that the opening slide, WHO Religions for Peace Global Conference. If you could have the next slide, please, Sarah. So this WHO strategy for engaging religious leaders, faith-based organisations and faith communities has a goal to enable more effective responses to health emergencies. It's by strengthening our collaboration between WHO, the national government and religious leaders, faith-based organisations and faith communities, we can hopefully result in more people being better protected from health emergencies, enjoying better health and well-being, and including improved trust and social cohesion in our responses. This is not new. This is something that many, many countries have been doing for many years, decades even. But I think what's exciting is that we've come together to articulate more clearly how we'll work together. Next slide, please. So the strategy defines how we're going to work together and articulates some of the ways that we've been doing so already. It outlines the respective roles and responsibilities of WHO and the faith partners. It's a guidance note for the WHO Secretariat staff for their engagement with religious leaders, faith-based organisations, faith communities and national governments in health emergencies, and to encourage inclusion of those faith partners in national responses, along with appropriate levels of funding. It's an advocacy tool that can encourage greater engagement with religious leaders, faith-based organisations and communities in health emergency preparedness and response, and a set of principles for both parties to abide by to ensure mutual respect and adherence to shared values. And it's a list of potential actions that can contribute towards achieving the strategy's goal. Next slide, please. One of the important things in the strategy is the set of guiding principles. And we have had a lot of discussion together in the group about how there are very many common principles between the traditions of faith and the teachings of the faith communities and those that the scientific community base their work on too. So this is a summary of some of the guiding principles of the strategy, but we have in the text a little bit more that fleshes that out. And I'd like to read that for you now. We want to respect human rights, gender equality and inclusion, and our partner engagements must be inclusive of different faith traditions and religions, as well as vulnerable and marginalised groups. They must be nationally led. WHO, religious leaders, faith-based organisations and communities, as well as other humanitarian and development actors will work together to support national governments in their leadership role in preparedness and response to health emergencies, to avoid duplication and gaps and maximise impact while we're continuously committed to sharing and collaborating in that evolving relationship that promotes mutual respect. We promote shared values. The partner engagement works towards strengthening health and community systems. It's not just a hospital setting that faith-based organisations work in, neither is it only a mosque or a temple or a church. faith-based organizations are drawing on their existing spiritual, moral, and social assets in the world's religious and faith communities. And we act together on shared values and teachings such as justice, dignity, equity, priority for the poor and most vulnerable, and person-centered care. Our work will be informed by data, and our engagement will draw on the best scientific evidence and understanding of community needs, as well as their issues and perceptions, so that we avoid mis- and disinformation. Together, we'll respect religious difference, engagements will seek to honour the identities of different communities, religious faith traditions. And we'll seek to be fully representative, engaging local, national, regional and global religious structures and representing all different faith traditions, working together with government and intergovernmental, non-governmental and civil society actors. Importantly, we'll be community-centred and accountable. Our engagements will include and draw on community knowledge and capacities, that knowledge of local vulnerabilities, and will be accountable to those who are most affected. We'll nurture trust, engagements that nurture trust as a critical component of responses to health emergencies. And we'll be open and transparent, communicating frankly with one another, clearly to the public, acknowledging that there is uncertainty and that there is emerging knowledge and mistakes can be made. Next slide, please. So I'm not going to go into a lot of the detail of this next slide, but I thought particularly the principles were very important to give you a bit more detail on. But in the full text, you'll find a list of collective roles and responsibilities that we've worked on together, a list of roles and responsibilities, particularly for WHO, and a list of roles and responsibilities for religious leaders, faith-based organisations and faith communities. And a lot of this is about co-developing our national guidance, about co-developing our global guidance, about co-developing some of the guidance we give for how faith-based organisations might manage very difficult issues such as funerals or bereavement in families, or having to close places of worship. One of the important things we looked at was how to respect religious freedom whilst not compromising the safety of those worshippers. And to have those conversations together to be able to draw up such guidelines in a particular epidemic where the transmissions may be different and have different consequences are important principles. And these are all outlined in some of the roles and responsibilities and ways we will work together. Next slide, please. So this is my final slide. And the final section of the document has quite a large table in which we outline 6 areas of focus. And this is really some of the activities that we can do together, the actions that we can do together. And under each of these topic areas, we provide examples of the kinds of things that have already been going on in many countries, as we've said, for many years around many different diseases. But fostering and building partnerships, making sure that we're inclusive and we're helping to build capacity and resilience. And I'm also keen to say that it's about building capacity in some of our staff who come from a scientific and maybe a secular background who are not so familiar with working with faith traditions, as well as building the capacity perhaps of some of our faith actors who need more information about the up-to-date epidemic and how it needs to be controlled. So that capacity building is 2 ways. It's a shared learning. We'll be communicating effectively and responding to the infodemic. There's a massive amount of information out there, as everyone knows, in this pandemic, and it'll be important to work together on finding some of the actual facts and being able to communicate those with religious language that people in religious communities understand. Got there number 3, that important one I just highlighted, of protecting the freedom of religion and belief, whilst in doing so making sure that we minimise risk of disease transmission. Together we'll advance a more equitable society and provide social, practical and economic support for families and communities adversely affected by health emergencies. The previous session that we've just run, you may be interested to listen to some of the webinars. Some of our faith partners were giving examples of the ways that they have provided practical, economic and social support to communities in the midst of the emergency. And even as their houses of worship have been closed down, the way they've moved into the community and provided other kinds of support has been incredibly appreciated by local communities. And finally, by providing direct health services to communities, we recognise that many faith traditions do also run hospitals and have medically trained professionals, clinics and outreach services into the community. I'll close there, but just to also point out that in that final table of the areas of focus, we've also listed a number of indicators and how this work will contribute to these sustainable development goals. So thank you very much for listening. I'll hand you back to Sarah, and you'll be able to find the strategy online fairly soon. Thank you.
Thank you very much, Sally, for providing that overview of the strategy. And our team here at HQ are working to get it online as we speak. So we expect to be able to share the link with you all imminently during this webinar. As these things happen, it's right down to the last minute, but we're very grateful for all the work and energy that's gone into getting this where it is today. And in particular, Alex, who works a little bit too much behind the scenes, but it's really her that's pushed this through. So Alex, a shout out to you. We'd now like to, I think, move on to the Kenya case study. So as both Sylvie and Sally have mentioned, Kenya really is an incredible and outstanding example of collaboration, not just in this pandemic, but in previous pandemics as well. And so we're very delighted to have with us today our colleagues from the country office in Kenya and the partners from the Ministry of Health and the faith partners together to share some of their experience with you here today. So our first speaker today is Dr. Nolaskus Ganda, who is the lead for the COVID-19 emergency response team in the World Health Organization office in Kenya. Dr. Ganda is going to give us an overview of the situation in Kenya and WHO's response. So Dr. Ganda, we welcome today. Thank you for joining us. And if you're able to unmute yourself and turn your camera on, we are ready to listen, and I will be, over to you.
Thank you very much for inviting me and my team here in Kenya to give really a brief of what is going on in the country and what we are dealing with. Maybe just to start, I was requested to talk a bit about the global updates and regional updates before coming to the country. For all of us, we are seeing globally that we have actually experienced 3 waves, and that is at global level, but at country level, it's equal. We have actually also experienced, not at regional level, we've experienced 3 waves. But the Kenyan situation, we have had four waves. The second wave was the worst. It really hit us. We had very many infections, very many admissions. But the previous wave, the current wave, which has just ended, the 4th wave, was very limiting, not as bad as the previous waves. And currently, as we speak in the country, we have seen a very low number of cases being recorded. In fact, over the last 3 or 4 weeks, we have seen a continuous decline in number of cases in the country. We are happy about this. It shows that our efforts are finally paying off. Our biggest challenge now is a continuous community engagement, and we are happy in the country office that this meeting is taking place now, because one of the key areas we are looking at when it comes to community engagement is the religious leaders. When it comes to risk communication and community engagement, we are having a bit of vaccine hesitancy. We're having a bit of complacency in the country, and we are looking at the religions group to really push this agenda forward for people to come out, to get vaccinated, to take the risk measures, so that we continue to have low number of cases in the country. In the previous wave, we had a lot of deaths deep in our communities. It is the first time, I think, as a country, Kenya, we have experienced such an outbreak where we have community fears, where something that was thought to belong to the cities finally hit deep in the villages. Elderly dying, middle level people in the community dying, and this was of concern. Key leaders dying because of the pandemic, and initially it is because people are not taking it seriously. We look to the religious community to help us in the health sector to encourage the communities to take every measure they can take, especially when it comes to vaccine. That's the biggest problem we're facing in the country, to take up the vaccines and so that we can continue to address the pandemic. Now, for us in Kenya, we are planning to continue responding to the outbreak the whole of next year. We have only achieved 6% of vaccination, which is very low. Our Director General has talked about the issue of vaccine equity in the world. Kenya is one of the countries which has not received and not given so much. If you look at Europe, they have achieved more than 70%. For the country, we are around 6%. And so with that, I want to thank you very much on behalf of my country director in the regional office and the WHO country representative for giving us this opportunity. My colleagues will share with you deeply what we are doing. And we reiterate the need for partnerships and for engagement with all sectors, including the very key religious sector. Thank you very much, and over back to you.
Thank you very, very much, Dr. Ganda, for joining us today and for providing those opening remarks and setting the scene for us with regards to the situation in Kenya. I'm very happy to hand over now to Dr. Jemima Mwakisha, who is the lead for risk communication and community engagement within the WHO country office in Kenya. Jemima is going to talk a little bit more in depth about the importance of the community engagement and the role of the faith communities in the response. So Jemima, please, thank you so much also for all the incredible hard work that you've put into organizing this webinar. It's been an absolute pleasure to work alongside you. So over to you, Jemima.
Thank you very much. This is most appreciated. I'm just wondering whether to share my screen or you'll do that for me. Thank you. Okay. So glad to be here and glad to be with everyone on this. Looking at the significance of community engagement and interfaith relations, please go to the next slide. So in the last almost 20 months, and Dr. Ganda has spoken quite a bit about that, we've been responding to the pandemic, starting off with a curfew and then closure of places of worship, a lot of that and different things that happened to help people to adjust to the pandemic and to follow guidelines. So a lot of support from government, that led in order for people to try and prevent transmission from themselves and from each other. So there was enforcement of safety guidelines. That's what we had, allowance of up to 1/3 members, and now we've moved to 2/3. So originally we had just 1/3, and then over time, now it's 2/3. Because of what Dr. Ganda spoke about, that we are seeing some relief and we're hoping it stays. But in response, a lot of risk communication and community engagement responses that has happened. We've had a lot of partnerships with interreligious groups, but also with many other partners in support of government to respond. Next slide. So our approaches for interaction in Kenya are perhaps like many other countries or other places where we consider community engagement as the heart of the matter, where if you don't engage with communities, then you won't access, you won't share information. The risk is high and people need to know what to do. So we've used community engagement as a key component of our response. We've used social mobilization, where you're creating awareness, where you have dialogue, you're using every possible way, to reach out to communities. We've used health promotion as well, every possible capacity, every possible channel. We've tried to use that to reach the communities. but just emphasizing the fact that community engagement has remained the core, because to be able to do any one of these things, you have to work with communities and engage them. Next slide. So we see it as a key tool, as a heart of response, really, because we seek understanding, participation, ownership, and empowerment of the communities, of the groups that we're dealing with. Community engagement enables collective vision and response when you sit around a table and you're able to work with communities and have them understand, what the issue is, have them ask questions, have them respond. Then they're able to adapt, they're able to change, they're able to accept what the situation is, and also to see the risk that they need to take responsibility for. So it enables appreciation of the risk at hand through information sharing. It helps with decisions about risk to health and well-being. And we can say that through the communities we've worked around the country with partners, we've all seen, working with women groups, community health volunteers, interfaith groups, co-ops, youth groups, transport, CBOs, community-based organizations. We've seen and know now, we've learned a lot from these groups, what counts, what matters for them to be able to respond. So we see that we cannot make any interventions against COVID-19 without engagement of communities, without working with stakeholders and partners to be able to hear out, to consult with them and to hear their voices. Next slide. Then with the importance of interfaith communities, we worked, for instance, at the beginning with community-based organizations at the coastal areas where we had very high numbers and we needed really to find ways to intervene. And we worked very well with faith-based organizations, Muslim-based groups in Mombasa that really set the pace for us, because then that means we had some examples to follow, some lessons to follow as we worked with other parts of the country. And this is critical because religious or interfaith communities are a source of inspiration, of comfort, of encouragement. That's where people go for all that. Faith is central to most people's life, and in Africa especially. And religious leaders have a strong influence on the members, on the believers, and on the values of their communities. So interfaith communities become very critical in working in an intervention of this kind, in a pandemic of this kind, because they have access to their members. So we're looking at some of the recent information that we're getting, some of the assessments and CAP studies, in which it shows that most people have learned about COVID and the situation and the extent and the efficacy. They rely, or their main source is radio or TV at 88%. But what we've seen is that the most trusted source is the place of worship, almost at 80%, which means that most people really turn to their place of worship to hear the right message, to be guided. And this makes it very critical as we collaborate, as we look at how we move forward with vaccination and with other needs for people to sustain those safety guidelines, that the faith communities have a critical role that they play. So they're even more trusted from this study than health workers, who are 75%, although that's equally high. Community health volunteers in Kenya are very active here, or IC materials at 74. So while all these are pretty high, we see that the faith communities hold, the highest place. So we see with this, we see that there's room, for more involvement and collaboration and interrelations with faith communities and interreligious groups. I think for more effective interventions, and with all the lessons that we've learned working together, I believe we're at a better place to work with them, to use their skills, to use their access and to collaborate in order to access people effectively and for the sake of saving lives. Thank you. Asante sana.
Thank you so much, Jemima, for sharing with us today and for your leadership in this area of work. Very happy to hand over to Dr. Salim Hussein, who is the head of primary health care in the Kenya Ministry of Health. Dr. Hussein, again, thank you for your leadership and the partnership that you have with WHO and the faith partners. We're very much looking forward to hearing from you. I will share my screen. We don't hear you very well, so speak once more. Let me.
Hello.
Now we hear you well. We hear you well.
Thank you. Good morning, good afternoon, everyone. As Sarah is uploading, I like to appreciate for the invitation to participate in this webinar. For us, it's a very important webinar, especially where we are bringing together the religious leaders, the faith-based organization, and faith communities working together with the national government and the WHO. Next slide, please. I think for us as a government, it is very important to put across that we follow the global leadership from World Health Organization in terms what they lay down, especially during emergencies and the pandemics. And there are several areas that the World Health Organization that has supported us in Kenya, looking at the issues of surveillance. We have had a lot of technical support and also material support from WHO. In terms of risk assessment and situation analysis, we did our risk communication and community engagement document with the support of WHO. We have a lot of equipment and tools that we've been guided by WHO. Looking at several documents that we have done with them. We also had the launch of the mental health document with the WHO, which mental health has been a very big issue currently in this pandemic, and we are glad that we were able to reach that position. In terms of bringing health products and technology, we also, our principal secretary opened a factory where some of these materials will be brought on board, and we are glad that WHO was in the forefront. Next. With WHO directly here in Kenya, especially during this intervention, they have supported us in two main ways. In our national policy, the guidelines, standards, and the development of these documents, we have had a lot of support. One, we actually adopt some of the direction, the guidelines that the WHO has had internally. They even give us the technical support and also resources to formulate and develop our documents. Then we have also had a lot of support in terms of resources from WHO in terms of finance and materials. Especially in the areas of community engagement, risk communication, generation of information, especially during this time, where it has been very crucial to know what is happening outside there, to analyze and how to tackle, especially the issues of the attitudes, the rumors that are outside there and the myths. We had a lot of support in terms of guidance and the tools that we are using to develop those tools to get these infodemics. We have also had a lot of support in terms of logistics and operation support. WHO were able to provide us with several PPEs, which were very useful, and especially for us in the primary healthcare space, where our community health volunteers really needed this so that they could do their work in the household, but also protecting themselves. We have had a lot of capacity building for our community health volunteers, for our county health management teams, and also the resource person in different counties, looking at Nairobi County as an example. We have also had a lot of support from WHO, where they've supported our public health emergency operation center in terms of infrastructure, but more so technically. Next. So we have been working with several religious organizations and other faith with the government. The government, when this pandemic occurred, 1 month after the pandemic, that was in April, actually the government started the Interfaith Council of Kenya, which has been of very great support to us. It has reached to their congregants. It has made assured that their places of worship and also their health facilities are adhering to our protocols and guidelines. Actually, we did a CAP survey and showed that our religious institutions in Kenya are some of the institutions that were actually following to the latter our protocols and the guidelines. We have also worked with other UN bodies like UNICEF, where we've developed guidelines, documents for messaging on this COVID issue. We have had several faiths where we have developed messages for this coronavirus, where we have had their religious leaders coming up and also documenting them in documentaries that they can reach to their congregants, but also they have supported us to have our corona messages with citation, with the spiritual citation, with citation from the religious books, which have been very helpful for the people to own, for the people to feel that they are being addressed within their own religious lines. We have also had implementation of, for example, vaccination outreaches with several religious organizations in terms of using the health facilities, but also the religious places like the mosques, the temples, and the churches. We have also developed a document where the different faiths can actually have health messages on COVID-19. Some of these pictures depicting some of the things that we have done with the religious fraternity. Next. Next slide, please. Yes, what we've been doing together as the three partners, that is WHO, religious partners, and WHO during these emergencies, there are several documents, for example, to deal with the dead bodies, to deal with NCDs, where we have picked from WHO what they have. We have customized that into our national level. And when we are customizing this, especially, for example, the handling of the dead, the dissidents, we really had a lot of input from our religious partners. So when we came up with the documents, we had a lot of input from our religious fraternity. Then during the implementation, actually, we can say they've done a lot of advocacy, publicity, but also monitoring that the congregants, especially in the institution, are following our protocols and guidelines. They've made sure that the congregants are adhered to those protocols. So we have a lot of implementation that we could not have done if our colleagues, our partners from the religious fraternity had not been complementary to us. And they currently continue doing continuous advocacy, communication, social mobilization to the different audiences so that they can continue to adhere to our government protocols. Next. So I think for me, I think we will have three ways forward or recommendation. One, we should have a meaningful and continuous engagement that is based on our different strengths between the government, WHO, and religious fraternity. And I'm very glad that WHO has started this. They have a strategy, a document on the same, and also bringing up this webinar. I think for me, this is a very good way to do things. Then I think there's need for all of us to move from being a disease sector to a health sector. Most of the time when we plan in the health sector, we plan with diseases, we plan with the treating. So I think we need to go a step further and actually do the health as it is defined by WHO. So in planning, we need to engage the different sectors all the time. We need to put into consideration the other social determinants of health so that we are not just dealing with the curative aspect. The last recommendation I'm thinking, we need all to start practicing health. We need to have our health workers to be religious. That is, they have to be conscious of the religious aspects of other congregants, other people. And then we also need to have our religious people to be healthy in terms of them putting health as a policy in their implementation and whatever they are doing or practicing. Last but not least, I think our hospitals need to move from just being curative and disease oriented, but to be really health promoting hospitals. Thank you very much for listening.
Thank you very much, Dr. Hussein. It really was a pleasure to listen to you. Apologies, I lost my mute button again. Even after all this time, I'm still struggling. Thank you very much for your presentation. Our next speaker is Professor Mohammed Karama. Professor Karama is the chairman of the National Muslim COVID-19 Response Committee. And Professor Karama, thank you once again for being with us today to share with us. I'll share my screen.
Yes, please. Thank you very much. I would like to thank the World Health Organization for inviting me to represent the Muslim community in this. And as you can see, we have two logos out there. I want to say something very briefly about that. We see that we came in as an emergency response to the COVID-19 response in March 2020 at the beginning of the COVID-19, but we are now transiting. We saw the importance of existence of this organization, so we are transiting to a more permanent situation where we shall be the National Muslim Emergency Response Organization that will be able now to guide us in future and also to participate in any other epidemics and pandemics that may come from the experiences that we have gained. Next, please. I want to explain that the National Muslim COVID-19 is a composition of medical professionals, doctors, psychologists, Muslim leaders, imams and madrasa teachers and sheikhs and other professionals such as accountants and so on, who join together to address this pandemic from an Islamic perspective. Next, please. The main objectives of this was to make sure that we complement the government effort in mitigating and controlling the COVID-19 pandemic. We did observe that in the initial stages, the government wasn't very certain of what to do. I would like to thank Dr. Salem Hussein, who has been our contact person with the Ministry of Health, working on the linkage between faith and working together. And we have learned a lot, and I think we have done a lot of knowledge management and whatever which we can use in future. The second objective was to use Islamic teachings. Most of the places of prayer, mosques, madrasas, and congregations were affected. So we had to convince the Muslim community from the religious perspective and from the scriptures on how important it is to abide by these guidelines. We also used the Muslim, both physical infrastructures, we used the pulpit to reach the people, and we also used the social capital involving Muslim organizations, imams and others to come up, to relay the messages and to sensitize the people and to work together with the government in this. And that is why it was very important to have the structures in place. And then we also used the media, Muslims media. We have radios, we have vernacular radios, we have TV stations that were very, very useful. And also the mainstream media that were there. We were able to use these to guide, to give information, and we would like really to thank all the support that we received. Now, we were also able to develop several guidelines based on the WHO, Ministry of Health, we also kind of Islamicized the context of the manuals for more acceptability amongst the Muslims. Next. I think some of the committees that we had to work with, because we observed that handling or managing COVID-19 was a very broad perspective. So we had a team that was handling the infection prevention and control. And this was to disinfect prayer places, schools, and so on, which were still open, or at least to ensure that the households were well taken care of. We had a committee that dealt with home-based care. These were where the cases were not very serious, and the home provided convenience for home-based care. So we had teams that would go around to provide this service from the Muslim community. As we are aware, it became very, very expensive to take people to hospitals. So the home-based care support was very useful. We had the sensitization committee and the media committees. We had the burial committees in the initial stages. We had to handle the dead in a dignified manner so that we get the support of the community. I want to say we also got requests from our Christian brothers and the Hindus to support them in handling their dead in a few instances in Mombasa and also in Nairobi. Mosques and schools inspection, these were prayer places and madrasas, Islamic education schools, which had to be closed and sometimes to be inspected and reopened. So we had teams that could do that. And most important, also we had psychosocial support. Many homes were very badly affected and people were traumatized. So these committees became very, very useful. Next, please. Some of the achievements that we did was that the government did recognize us, and we worked together very closely, and we were well represented in the Interfaith Committee. We developed Islamic sensitive home-based care guidelines that are in line with both WHO and these documents are very useful up to now. Dignified and accepted burial guidelines. We had numbers of people dying per day, and therefore we were fully engaged, and we established the branches also. We had manuals on mental health, psychosocial support, the first aid, psychological first aid. We also addressed the volunteer fatigue and community stigmatization. I think there was a lot of fatigue as the pandemic continued. And then the crept in was the stigma that was coming up, and also the denial. So we had to address this through the psychosocial support, and then sensitization for vaccine uptake. I think this is ongoing up to now, and we believe we created centers where vaccination can be done against the many, many social media and myths that are given in this area. Then we also established a 24-hour toll-free telephone, which was very active. Next, please. The challenges that we experienced during this was that strategies that polarized the community in the early stages. There was too much use of the law and force kind of enforcing. But that was understood that at that early stages, the government had to be very strict in ensuring that things were done in the right way. Volunteer fatigue is another issue due to the extended lack of incentives and so on. Then we had high cost of hospitalization for severe cases. And this is why, again, the home-based care was also very important. Misguided social media statements. There was so much against COVID, against vaccination, against handling of the dead, and against many, many things. And people created a fear for the health facilities. So in many areas, public health facilities, the uptake of healthcare went down to a certain extent. I think what we are concerned is that maybe the government relaxed the rules. One of the areas that we are concerned is the public transport, where they had restricted the numbers, keeping the social distance. but this was opened up based on the economic, but I think this was done a little too soon. Next, please. These are some of the pictures showing some of our activities, the handling of the dead, and the prayer session. The photo down, we had to pray instead of in the mosques and whatever. Our imams had to do this in the graveside to make sure we reduce the opportunity of transmission of disease. Next. These are also some of the posters that we created for the different occasions, like during the Eid celebration, also during the slaughtering of animals, and stopping the mass gatherings of people in homes. And these were very crucial to the Muslims because they get together during celebrations, and these were important also. Next. These are sessions of training that we conducted in different facilities for both men and women on how to handle these issues. And these were very, very well supported. And we really appreciate the government support in handling some of these situations. And we are very grateful to both the government, the Ministry of Health, and the WHO for organizing this. And we hope that we will now work together more effectively to ensure that we don't relax the rules very early, that we can continue with the surveillance to ensure that the pandemic is put under control. Okay, thank you very much. Next, please. These are again the photos where we distributed water tanks to different communities, where we emphasized on hand washing and the trainings. I think that's the last slide. Thank you very much.
Thank you very, very much, Professor Karama, for sharing with us the incredible work that has been done by yourself and the National Muslim COVID Response Committee. Our next speaker is Bishop Dr. John Warari. Bishop John is the Executive Board member of the Interreligious Council of Kenya and a member of Interreligious Kenya as well. So Bishop John, I believe that you have slides and will share them yourself, is that correct?
Unfortunately, Madam, my laptop just locked, and I'm having some challenges here. And I take the responsibility, but I can just provide what I have, and I hope we will send the slides to your office through our sister Jemima.
Absolutely, it's a pleasure to have you. Please go ahead.
Thank you so very much, and happy day, everyone. I would like first of all to share my gratitude to the World Health Organization, the Religions for Peace, UNICEF, UNDP, our partners, and all the members of Interreligious Council of Kenya. The Interreligious Council of Kenya, that is IRCK, is an umbrella body of all main religions organizations in Kenya. And these are the Kenya Conference of Catholic Bishops, KCCB, the National Council of Churches of Kenya, NCCK, Evangelical Alliance of Kenya, EAK, Organization of Africa Instituted Churches, OIC, Kenya, Seventh-day Adventist Church, the Supreme Council of Kenya Muslims, SUPKEM, National Muslims Leaders Forum, that is NAMLEF, Shia Ithna Muslim Association, and the Hindu Council of Kenya. We exist as 9 formations, and we have been here for quite a while. And our mission is to promote tolerance and understanding among faith communities in Kenya through mobilizing joint actions for socio-economic development and a vision of faith communities who are living in peace. We value peace, united in socio-economic action for the nation of Kenya. Like many other institutions, the interfaith response to COVID-19, after the first case was reported in the country in March 2020, was with mixed fear and doubt, as no one knew what to expect from the pandemic. So Interreligious Council of Kenya responded in many ways, ranging from generation and dissemination of messages of hope, as well as correct messages on COVID-19 for dissemination in the places of worship. We are all aware that when the onset of this disease, there was a lot of panic, and people didn't know where to look to. But like Dr. Jemima has said, that the trust that the nation has in the religious leaders is unequaled. And so they listened to us, and they still do. And we started giving them hope. Of course, we offered prayers, and most importantly, shepherding. We were there. We call it the ministry of presence. We felt we needed to be there. Of course, we had to be careful, and we had to follow the protocols. And it worked so much and very well, because it reassured the citizens and the people in the nation that all will be well. And I thank God that these messages of hope, which we put in pamphlets that were the language of the people. For example, we had some in Hindi, others in Swahili, from quoting from Christian Holy Bible and from the Quran, so that people can feel that they are not alone, and that their hope was alive. And this one worked out very well. So in the many ways that we responded, we also had to come up with correct messages on COVID-19, because there were many myths and incorrect messages, and we used these in our congregations. We also used social and mainstream media platforms, and we developed and disseminated correct messages on COVID using congregational media platforms to dispel fear on COVID-19. And we had advocacy with the government as it introduced to introduce measures to cushion the poor and non-working Kenyans affected by the COVID-19, especially those in informal settlements and urban areas. It is found out that over 3 million Kenyans lost their jobs and livelihoods. And the 3 million, if each had 5 dependents, you can imagine that so many Kenyans were affected. And so we spoke and lobbied with the government so that they can give relief. Our religious organizations came up with coupons which the most needy could access, and go with them to the supermarket and get some rations or some food. And we were available. We were on the standby to help in medication need, because again, people were not able to access their medication, and because of curfews, the religious organizations were put in the bracket of essential service providers, such that with that card and identification, the religious leaders could travel even during the curfew and supply or give services while they were observing the COVID protocols. We documented myths and misconceptions around COVID-19, the spread and prevention measures. So through our congregations, because Kenya is a very, very highly spiritual society, 98.6% of Kenyans, they are very, very spiritual, and they belong to one faith or another. And so through our platforms, we were able to reach them and speak to them about this enemy. We held sensitization meetings with different members of society, and in particular in Mombasa, our coastal region, where Women of Faith Network was available, and we spoke on mental health, interfaith cohesion, because again, this was very important, like Professor Karama has put it very well, that other religions reached out to them for help, the Christians and the Hindus. So there was, and still is, a superb cohesion among the religions in this nation. And so we were able also to be very strict in our places of worship. When we were allowed to open, we followed, and we are still following all the protocols and the directives of the Ministry of Health. So in Mombasa, we also offered support with the Women of Faith members, mother-son, daughter dialogues in Maskan on how the youth can remain, still have good mental health during the COVID-19 period. The issue of mental health was very, very important, because many people are having been restricted in their homes. They started having repercussions. For example, the issue of gender-based violence was on the rise. Underage pregnancies was reported, and all that. And so we needed to help in counseling. As I said, our work was to shepherd and be there when need arise. And so with that, we had a very intense training with the Ministry of Health and some major universities here, where they trained caregivers, and they trained psychosocial, psychiatric, as well as psychological personnel from the religious organizations. And we came up with a toll-free number that would operate 24/7. Anybody with a crisis of a mental issue, they would call, and the trained personnel would respond. And if the matter could go through counseling, we were doing so, and we are still doing so. And if it needed referral, we would do that. And so the findings that that was found out was that it was important that the government should continue giving funds towards helping and alleviating these problems. And we saw that the funds in the year 2021 was less than what we had 2020 when this nation was hit with the COVID-19. And then we had a very unique problem, because majority of public schools, they lacked basic COVID-19 prevention measures, like masks and thermogans, isolation rooms, and clean running water. There were shortages of toilets for both boys and girls in many primary schools, and the religious organization were able to help come up with the organization for helping get funds and lobbying with the government. I want to believe I still have some few minutes.
Thank you, Bishop John. I think we need to move on quite quickly to the next speaker in the interests of time. So
very well.
If you are able to wrap up, that would be wonderful.
Thank you. I think then what I would underline is one, the collaboration that we have with the religious organization through Interreligious Council. It's superb. Like Dr. Sally said about trust and the very well cut out roles and responsibility. So again, I would say the collaboration we have received from our partners, from the government, from the religious organization is super, and we are willing to continue with this journey. Over to you. Thank you.
Thank you very much, and very sorry to have to hurry you along. I want to just remind everybody that we do have some time for Q&A, so we have received quite a few, and we'd love to get round to answering some of those. Our final speaker in this portion of the webinar is Linus Ntagai. Linus is the Program Manager for Health and Social Wellbeing in the Interreligious Council for Kenya. So Linus, thank you very much for joining us today. You have the floor, and I believe Alex has your slides and will be sharing them. Linus, we don't hear you yet.
Thank you. Can you hear me now?
We hear you now.
Thank you all. Good morning and good afternoon. This is Linus from Interreligious Council of Kenya. To add to what Bishop John Warari shared, we thought it's important also to share something specifically on what the Interfaith Council on COVID-19 has done in Kenya. And this is the Interreligious Council is a body that was formed by the government of Kenya through a Gazette notice, that's 976, on 12th June 2020. And it is a body that is made up of religious leaders. As highlighted there are 16 religious leaders drawn from 9 faith bodies. And you'll notice that these are the same faith bodies that form the Interreligious Council of Kenya. And also Interreligious Council of Kenya, together with the Ministry of Interior and the Ministry of Health, they form the secretariats of the council. Therefore, the point number 3, any implementation and all the actions of the council are implemented by the 3 bodies, that is the Ministry of Health, the Ministry of Interior and the Coordination of National Government, and the Interreligious Council of Kenya. Next. So before you go to the mandate, I think we would like to appreciate that the government of Kenya did notice the role of religious leaders in the country. And this notice was also recognized through the formation of Interfaith Council and granting the mandate to the council to be able to develop all the protocols that were meant to guide enforcement of COVID-19 rules in places of worship, and also basically to be the mediator between the religious sector and the government to be able to negotiate on what is good for the country and what is good for religious leaders and the religious sector, especially in places of worship. So it was a great honor, and we appreciate. So the first mandate of the council was to develop protocols on faith reopening. You will notice that the council was formed after all the places of worship were closed. Therefore, the council had the mandate to ensure that to develop the protocols that will guide on how the place of worship will be reopened. The second one was to give the progressive resumption of in-person worship, basically to guide on how people will go back again to meeting in churches, at the mosque, at the temples. And the third one was to guide on how men and women of faith will go back to celebrating weddings and other religious ceremonies. So the council was mandated to provide protocols and guidelines on how weddings and other religious ceremonies will be celebrated in line with the COVID-19 protocols, in adherence to the COVID-19 protocols. And then we were also to develop the protocols on funerals and the graveside ceremonials, basically to ensure that when people attend funerals, they adhere to COVID-19 rules. So, and in this case, as you see later, we developed the protocols that distinguish between COVID deaths and non-COVID deaths, and this was clearly implemented. And then the council was to do public sensitization on COVID-19 adherence. Then lastly was to prioritize reopening and the number capping applicable for places of worship. That is at what point we have all the members attending churches and mosques and temples. At what point do we have a third of the number? So that was the last mandate. Next. So these are some of the achievements. We developed and disseminated the protocols for reopening of places of worship in the country, which were disseminated well and enforced. And I think this is a great contribution to what the Ken was saying about the religious leaders and religious institutions being identified as the structures that strictly adhere to COVID-19 protocols. The second one was the development of the guidelines for gradual and progressive resumptions of in-person congregational worship that adheres to physical and social distancing. Yes, I think this one you will see later on how we managed to do this when we developed and published and disseminated protocols on how weddings should be celebrated. And this we communicated to our congregants and our members, and their adherence was close to 100%. Then we formed and supported 47 county COVID-19 interfaith committees. These are committees at the county level that oversee COVID-19 adherence. And these committees have the mandate to close any church or any mosque that does not adhere to the rules. So the COVID-19 county committee are a branch of the Interfaith Council. The council sits at the national level, and at the county level, we have the COVID-19 Interfaith Committee, and then we also have the sub-county level. So if any church or any mosque or any temple is not adhering to the guidelines, there is a mechanism through which enforcement is done and adherence is done. If this fails, then the county committee have the mandate even to close down such a church that is a threat to its members. And lastly, is building capacity of religious leaders and the clergy on COVID-19 guidelines on in-person worship. Next. Yeah, so these are some of the protocols in summary that we developed. So these are protocols on faith participation in religious rites, norms for public worship, So basically, these are we prepared these as posters. We made these as posters that were easy to understand, and they were distributed in almost all the churches that were participating at the mosque. So they were distributed to the county level, and the county level team took them to the sub-county levels, and the sub-county levels took them to the individual congregations. These are the churches and mosques and temples. Basically, with this, it provided a very clear guideline on how to participate in religious rights. You'll find that it's about wearing of masks. So it's about the COVID protocols and what needs to be done in a simple way. And these were given after the training was done to all the religious leaders. So it became easier for the religious leaders to explain to their congregants on what their adherence means. Next. So the second one is the phased reopening of places of worship. So this provided guidelines, and I can report this basically is what the president has been using. So every time there is a presidential speech or the number of congregants that should be meeting, this is what the president and the government uses to guide on how the number of people who should be attending in-person worship at any particular time, depending on the infection rate. So we did provide this, and every religious leader, the churches and the mosques and the temples have this that guide. So when we say a third of the number, it is very clear they can follow on who to come and how to come. And these guidelines also gives the numbers based on the risk factor, like those who are old, like the pre-opening phase, you find that basically it's for people who are strong. The second phase, so up to phase 4, that is the green phase 4, that is when people with existing conditions and those who are old, that is when they are allowed. So especially from pre-opening to phase 3, the infection is still high, and therefore you find that some people are not expected. And this one is part of what the Interfaith Council enforces to ensure that there is adherence, so that we do not put their lives at risk. Next. Yeah, this about the phases in participation in religious rites, especially funerals. Again, this is a phase based on the infection rates. So you find that the pre-opening is initial, but the red phase is when the infections are high. So we require 100 people. The first one is a pre-opening is 15 people, and this is only at the graveside. At phase 1, because the infections are high, the number is limited to 100 participation at the graveside, 15, and the duration is capped to maximum 1 hour, while there's no food that is allowed. So this was a guideline. And as I said, these guidelines were placed in place of worship, and they were given to the religious leaders so that when a declaration is made, they can easily follow. They use them as a point of reference on what needs to be done and when it needs to be done and how it should be done. Next.
Just a quick timing warning, Linus, if that's okay, we can
Okay, thank you. I think this is the last one.
Okay, wonderful.
And this is about the weddings. Again, for the weddings, we have given it phases from pre-opening to phase 4 when COVID will be minimal or there will be none. Next. Yeah, thank you. I think that is all. Thank you.
Thank you very much, Linus. And again, apologies for having to hurry you along towards the end. We do want to just allow some time for Q&A, and I'm going to hand over to my colleague, Dr. Jemima Mwakisha, who's going to moderate this part of the webinar. We have had quite a few questions coming in, and I believe that Professor Karama, you've already been quite active in the chat, well, at least in the Q&A, answering some of those, so thank you for that. But Jemima, over to you now. I think you have some questions lined up for our panelists.
Thank you very much, Sarah. I know we don't have a lot of time, but from Samira, she or he is asking, in working with faith leaders, not all are providing a listening ear to the science. So in that case, how do you cooperate? For example, let's use the response that the vaccine is not needed because God will provide protection. So do you convince them that God will provide the protection, or what else? I had this experience in Sri Lanka and used that strategy, but I'm not sure it's scientific. What is your experience? I'm thinking of Bishop Warai. Do you tell someone that God will save them and therefore maybe they don't need to take the vaccine? How do you deal with that situation? Thank you.
Yes, we've had, thank you so very much, Jemima, and that is a very good question. We've had people, and especially among the clergy, struggling with the issues of faith healing and comprehending about interventions that could come through faith or through medicine. But we've tried in our groupings as religious leaders to educate and bring home or close to home those people who advocate for only faith healing, and we would gladly say that the clergy now, they are well informed that science and faith, they complement each other because there is no conflict in between. So it's a matter of working with the weak who just believe in faith healing and trying. And again, we've also become role models. For example, I went out in person and I was I brought in our media so that they could see see me receive vaccination, COVID-19. And so it's a matter of time. It's not easy, but working with them, and we've been the role model and telling them that science and faith, they are not in conflict, they complement each other. Thank you.
Thank you very much. Thank you very much. From Salom, it's also known that one of the factors which prevent many religious people to use medicines, for example, vaccines, is because many materials used in processing these were sourced from animals, which were prohibited according to the specific religious scriptures. So I wonder what your efforts to advise big pharmacies and big pharmaceutical industries to try and solve this issue, for example, to explore other options. Dr. Salim and maybe Professor Karama. Dr. Salim? I don't know if you had the question.
Yeah, maybe I can address that while Dr. Salim is trying to come up.
Thank you.
I think what we need to understand is that some people believe that COVID is the work of the devil. It cannot be. God is still in control at all times. Nothing will happen to the human race without God's permission. So God has a purpose for giving us this trial and challenges to address so that we can be stronger we can see very many outcomes of this COVID that we are now able to work together. We're able to learn more. The globe has come together, and therefore, and God allows us to consult those with knowledge. And if the medical practitioners are entrusted with working with vaccines, this is all with the power of God. And therefore, we should not reject science under the pretext that God will protect us, because God says, please do what you can from your part, and then God will also help you. So we have to do what is humanly possible for God also to help us. Thank you.
Thank you, Professor. Dr. Salim, are you there? So I have another question. Oh, okay. We can't hear you, Dr. Salim.
Can you hear me now?
No, yes.
Yes, I was saying in terms of production of the vaccine, it's not all of them that are produced by using maybe animal products. Most of them, they have a genetic engineering that is being used. But if in case there are some, not just vaccines, even medicine, so we will talk to the manufacturers, and if it is possible for them to have mechanism that they can produce either these vaccines or medicine without using animal products. So they're usually alternative. But I think in the case of these vaccines, we can say most of them, the genetic engineering that is used will avoid most of the animal products. Over, thank you.
Okay, if you can stay on, thank you very much for that. Another question is from Mona. I was in Kwale County a few weeks ago and was talking with someone who said that they didn't trust some of the messages coming from imams because he thought they were being paid by the government and he doesn't trust the government. Have you been hearing those kinds of messages within Kenya, and how do you reply?
I think that could be a possible thing from some people. I think there are various issues in terms of perception, trust issues that are there. It's possible they could be there. But I think what is most important is for the ministry, for the religious leader, whatever they portray, whatever they're putting across, when they have a rationale behind it. For us, it is most of the time is scientific, but for the religious leaders, I think they can refer to their scriptures, and if it's something that is allowed in their scripture, in their religion, then I think it should be able for the congregants to follow. So if the person says that the information is being given is not true, but it is according to the religious scripture, I think it's more probably that the person will actually accept. So I think for such people, it's for us to give them the facts, to talk to them nicely, to try to convince them, and also if it's possible to use their peers. I think these issues of mistrust, they are there, but we need to use several mechanisms to address them. Over, thank you.
Thank you. So the government can use mechanisms to deal with mistrust. Thank you very much. From Jagannatha, should it not be good to trace the public health architecture traditionally with religious scriptures in the WHO strategy and guidelines? And I'll ask Sally if you can answer that. Sally Smith?
Sorry, I was typing the quotes. Could you please repeat the question? Thank you.
Okay, so should it not be good to trace the public health architecture traditionally with religious scriptures in the WHO strategy and guidelines? That is from Jagannatha.
Jagannatha. Professor Karama, did you want to answer? No. So I think one of the things that's important is to work together with the religious communities for them to identify which of the religious scriptures from their own tradition work well along with the particular medical guidelines that are being given. Then there's a sense of ownership. It's about co-developing. It's not about WHO picking and choosing different religious scriptures that might support their messages, but actually it's that building of trust together as we work together to build both the messages and the supporting scriptures. So that will be my response. Thank you.
Okay.
Thank you, Sarah. I think, Jemima, this is a good question. I think we have done a lot of knowledge management, our learning experiences from these activities, and we can keep this record to share for the future and work with WHO and other organizations to address any other future pandemic. I think we learned a lot through this pandemic, and we learned a lot from the scriptures, Islamic and otherwise, from the teachings of the Holy Scriptures, both Christians and others, and Muslims. And we can keep this on record. It helped us to do the quarantine. It helped us to do the isolation. It helps us to also request distancing and so on. There was so much of learning from the scriptures, which can also be used in future. And thank you, Sally, for that response also.
Thank you. From Kristen, I would like to know if you have control of the unregistered churches and how would you bring them on board? So that would be to Bishop Warai or Linus.
Yeah, thank you so very much.
How you deal with unregistered churches and how you can bring them on board.
Thank you. Yes and no, in that non-registered churches in Kenya, actually, they are not legal. And for this reason, that is why the Interfaith Council is working with the Ministry of Interior, which is in charge of law enforcement. So if a church like that is identified and it doesn't have the structures, neither does it have a mother church or control where it has a leadership, then the Interfaith Council brings in the Ministry of Interior, that is the police, and the provincial administration, who then close the church. So that is the reason why there's the networking between religious leaders, the Ministry of Health to provide the technical information, and the Ministry of Interior to enforce where religious leaders cannot enforce. Thank you.
Thank you very much. From Samira, by working with faith groups to develop guidelines, especially for functions like funerals or weddings, did the compliance improve among the general public? So perhaps that could go to Professor.
This was very challenging because traditionally, especially amongst the Muslims, people show concerns during funerals, and when they're invited, it's mandatory to attend weddings. It was very difficult to align ourselves to the new regulations. But using again the scriptures and using again the situation as it was, we got quite good cooperation in the early stages where we handled the dead until when the ministry said they started relaxing the rules. I think we got a lot of cooperation from the people, despite that, it was a very difficult thing to accept that your wedding, you have only 100 people and so on. But people abided to that, and we really appreciate the support. Thank you.
Thank you very much. I think we had an initial question, which I think has been answered, in which Samira was asking about context, about examples from the different church groups and how it has worked. I hope we've answered that. I think that's about it for the questions.
Wonderful. Thank you so much, Jemima, for channeling those, and thank you to all our panelists for your answers. I hope you are keeping an eye on the chat where people are showing their appreciation. So thank you to everybody. We're slightly over time, but before we close this webinar, I would like to hand over to Jimmy Obuya, who is from the Faithful Positive Change for Children, Families and Communities Initiative for Religions for Peace. And as I mentioned previously, Religions for Peace is a co-host of this global conference, and we're just delighted that you, for this collaboration and partnership. And Jimmy, we're very happy to hear a few closing remarks from you before we hand back to Dr. Ganda, who will close for us. So Jimmy, the floor is yours.
Thank you very much, Sarah, and thank you for the wonderful coordination and also participation. Religions for Peace has committed itself to mobilizing and engaging its entire movement in a global effort to serve, especially during this pandemic. And we are really happy and honored to mobilize our national interreligious councils in 90 countries across the world in responding to COVID-19, and also in partnering with WHO, not only in dissemination of public health guidelines, but being invited into the space to co-create and integrate scripture, as we have heard from the examples from these Kenya case studies. The collaboration across with the Ministry of Health, religious leaders, and other faith actors indeed brings a wonderful and important lesson that this pandemic has taught us, that we can still work together and be a force for positive change. And also, Religions for Peace will continue to build a solid partnership with WHO and other stakeholders and assess avenues for continued strategic engagement. So we are very delighted to be part of this webinar series, and we're looking forward to the other case studies that are coming in the next couple of days. So thank you very much, everyone.
Thank you very much, Jimmy. I would now like to hand over to Dr. Ganda again. As mentioned previously, Dr. Ganda is the lead for the COVID-19 emergency response team in the WHO country office. And Dr. Ganda, can you give us some closing remarks? Thank you for your time.
Oh, thank you very much, Sarah. It's been a very good session. Had very good presenters, listening to Salim, my friend and colleague at the Ministry of Health, Professor Karama, the details of your work and how you adopted to the pandemic. Bishop Rari, for the very detailed presentation on the collaboration that you have briefed us on. That it's indeed very strong, as you have said, and it was quite new for me to also know this, or most of what you've talked about. Linus, for the council, I've seen the mandate. Happy to know that the Interfaith Council is directly advising the president. And indeed, for us out here, we have been following the advice from the Interfaith Council, and with a very strong mandate to lead the country and to advise the country on how to engage. Jimmy will be here for closing, and of course, I'll not forget Sarah Hess for chairing this session and for, of course, engaging us. Sally, Sylvie, and Jemima also. From me here in Mombasa, Kenya, thank you very much to all of you who have participated in this session. We look forward to more sessions where we can engage and also learn from each other as human beings from in different parts of the globe. Thank you very much, Sarah, and all of you. Back to you, Sarah.
Thank you very much, Dr. Ganda. No, nothing really more from me, but just to say thank you for the wonderful collaboration and all the speakers here today. We look forward to continuing the conversations and documenting this amazing case study. Tomorrow, we will be learning about Zimbabwe. So I think Alex has shared in the chat the registration links for that. So we look forward to welcoming you back for that presentation, and next week the Philippines. So there's a lot of learning and shared learning going on. So thank you, everybody, and see you all again soon.